So it's my privilege to give you an update on the introduction of novel therapeutics into the combined modality paradigm in locally advanced non-small cell. There we go. So my disclosures, this is the positive trials in of chemo-radiation, other approaches in locally advanced. And if you look closely, the benefits have really been seen either in the induction or concurrent setting with radiation as opposed to radiation alone, or for concurrent over sequential. To date, we've not seen any positive trials in the consolidated setting, targeted therapy, or as you'll hear from Jeff, dose escalation of radiation. All of those are in red, but to this I will add in yellow immunotherapy, because the Pacific trial so far shows a striking benefit for disease-free survival, but we have yet to see the OS data. It doesn't mean it's not negative or not positive. It's just that the data aren't mature enough yet to really discern. And so until we see those data, I cannot really convert that to the green color. Last I checked, in the curative setting, you still need to increase cure rates. Here are the probably most influential trials in locally advanced for sequential versus concurrent. And the two largest trials, the Japanese trial by Furisi and our own RTOG effort, had virtually identical results, showing a significant, and I'd argue clinically meaningful improvement in long-term survival for concurrent over sequential or asynchronous chemoradiation. Payoff with survival, the payback, unfortunately, the major problem with all of this, of course, is in-field toxicity, particularly esophagitis. There's been a meta-analysis. Anytime you have multiple trials that look alike, you will see a meta-analysis. This is by Oprin and colleagues, published about a decade ago, looking at 7 separate trials, over 1,300 patients. You can see the demographics. The absolute survival advantage at about 5 years is roughly 4.5%. P-value is significant. The hazard ratio is modest, but still significant at 0.83. Again, with a 6-fold increase in esophagitis, but no significant difference in long-term pulmonary risks. And here are the curves. On the right of the PFS curve, on the left the OS curve, and you can see by about 1 to 2 years the separation is clear. There are many ongoing therapeutic issues. I'd need 2 hours to go over all of these, and I'll really confine my comments to targeted therapy and immunotherapy. And you'll hear a lot more from Jeff regarding new radiation technology and dosing of radiation, and also hear from Jessica on the role of surgery. So we'll cover 3 separate topics: angioinhibition, EGFR inhibitors, and of course immunotherapy. And for angiogenesis, there have been 3 separate trials, all of which I think have really shown the danger of integrating angio inhibition with our standard chemoradiation approach, either danger or lack of efficacy. This is a large trial through ECOG, published about 5 years ago in JCO, that looked at thalidomide, putatively an angio effect, although it may have other approach effects. Basically testing this in the context of induction PAC carbo, followed by RT plus or minus thalidomide. It was later amended to allow concurrent chemoradiation. You can see the doses. The study was closed early at the recommendation of the Data Safety Monitoring Committee because of an increased risk of thrombotic events and no obvious increase in survival. And if you look at the problems here, before they amended the study to allow low-dose baby aspirin to help mitigate the thromboembolic events, and both before and after that amendment, thalidomide still resulted in a higher incidence and no obvious difference in survival. And again, here are the PFS and overall survival curves. So an interesting concept at the time, but certainly not something that we are doing even routinely. More cogently looking at bevacizumab, which of course has shown a benefit in stage 4 recurrent disease. SWOG attempted to integrate this into the combined modality paradigm, initially during docetaxel consolidation, and then in a second cohort midway through chemoradiation, and a third cohort at the initiation of it. It was suspended and then aborted because of a high incidence of in-field toxicities, particularly pulmonary hemorrhage as well as fistulae. And then a couple of trials from Sarah Cannon. This is a small cell trial, a little bit off topic, but integrating bevacizumab with irinotecan and platinum, both before and during radiation and limited disease. 29 patients, 2 developing tracheoesophageal fistula, 1 patient dying from an aerodigestive hemorrhage. You do the math, that's more than 10% grade 4, grade 5 horrible toxicity. Another patient dying of bowel perforation. They tried doing the same thing in non-small cell, integrating Bev with chemoradiation, and 2 of the 5 patients also developed tracheoesophageal fistula. Bottom line, do not give angiogenesis inhibitors during chemoradiation for definitive disease. And frankly, I think a lot of us have extrapolated that even into the palliative setting for thoracic radiation, that there are real dangers. And I have personally seen both fatal pulmonary hemorrhage and also a grade 4.5 tracheoesophageal fistulas, where you could drive a matchbox car through the fistula connecting the mainstem bronchus and the esophagus. What about TKIs, or for that matter, monoclonal antibodies targeting EGFR? Here the data are a bit mixed. SWOG 0023 was one of the first efforts. Remember, erlotinib, for that matter, initially gefitinib, were approved in unselected patients outside of the mutation setting, and this was an attempt to see whether it would have any influence on survival in the curative setting. So SWOG took its platform of platinum etoposide RT followed by consolidative docetaxel and then randomized to maintenance, gefitinib, or placebo. So I served on I continue to serve actually on the SWOG Data Safety Monitoring Committee, and I'll never forget the meeting where they showed these curves. And I thought, holy cow, look how good gefitinib is, until I saw the labels. The bottom curve is gefitinib. The top curve is placebo. So any people working in the pharmaceutical industry, if you want to market placebo as something superior to TKI in this setting, you probably have the data. 13% drop-off in 2-year survival. To this day, we do not know why this occurred. Unfortunately, tissue was not collected routinely to look at molecular profiling. It really predated the molecular era. And so the negative results of this trial remain a tremendous mystery. But again, outside of a clinical trial, and specifically focusing on those with oncogenic drivers, I would not use a TKI in this setting. That certainly hasn't stopped us. Number of both cooperative group and individual institution trials that have attempted to look at this. These are generally small efforts with mixed results. Just an example, CALGB, looking at induction PAC carbo with gefitinib in the poor risk group. They got concurrent RT and gefitinib alone. In the better risk group, good performance status, less than 5% weight loss, they got all 3, chemo, radiation, and gefitinib. And intriguingly, it's the poor risk group that actually did better. The black-blue curve is the strata 1, the poor risk group, with a median survival of over 18 months. And that was carried forward a phase 2 trial led by Rogerio Lellenbaum, now at Yale, where they gave NAB-PAC carbo induction for 2 cycles, followed by RT with concurrent erlotinib. And this has just been published 2 years ago. 78 patients, again, largely PS2. Third of these patients were over 75, response rate 67%, median PFS 11 months, median survival about 17 months. Again, it's phase 2 data. It's not something I'd standardly do, but some of the best results we've ever seen in this setting. It makes a lot more sense, I would argue, to target those who have activating mutations or oncogenic drivers like EML4 translocations. Remember, the initial Lung Cancer Mutation Consortium data showed actionable, or at least potentially identifiable oncogenic drivers or resistance in over 50% of patients. This is one of the original patients responding to an EGFR TKI who later turned out to have a mutation. Patient with ALK-positive disease, metastatic, responding beautifully to crizotinib. You'll hear more about that, both TKIs and ALK inhibitors tomorrow. So the current trial, which is still unfortunately on life support because of problems with accrual, is the Alliance RTOG effort that takes folks with mutations, EGFR mutation, randomized to chemoradiation alone or 3 months of erlotinib, followed by chemoradiation. Those with ALK fusion proteins, chemoradiation alone, or crizotinib for 3 months, followed by chemoradiation. The control arm, again, is chemoradiation alone. What about monoclonal antibodies? Well, cetuximab in combination with radiation has led to additivity, if not synergy, in combination in xenograft models. Certainly, we've seen, this is the A431 xenograft, where you see about a 4.5-fold radiation enhancement ratio for the addition of cetuximab to radiation. And we have data, of course, in locally advanced head and neck, where concurrent RT and cetuximab clearly showed superiority to RT alone. You see about a 10% absolute improvement in long-term survival at 5 years and about a 20-month improvement in median survival. We also have phase 2 data. This is through the RTOG, grafting cetuximab onto the PAC carbo radiation platform. The median survival that really been unprecedented in our experience, nearly 2 years, 22.7 months, and comparing quite favorably to historic controls using either the same chemo regimen or older chemo regimens like vinblastine and cisplatin. So that led to a modification of 0617, which was a phase 3 trial testing higher dose radiation, 74 gray versus 60 gray, with chemo PAC carbo. The trial was amended early on to allow cetuximab both concurrently and during the chemo. Dr. Bradley will focus a bit more on this, but the high-dose arm was actually inferior to the standard dose arm with poorer survival. Note that 28.7-month figure for the low-dose arm. If we look specifically at the group, the cetuximab randomization, some interesting observations that I want to go back to when we get to immunotherapy. More than 90% of the patients on this trial had PET staging, something that's almost standard now in North America. You see about 56% were non-squamous, about an even distribution between 3D RT and IMRT. Majority, over 60%, had stage 3A. Toxicity, as you'd suspect, was worse for cetuximab, although not egregiously worse. So you see a somewhat higher rate of grade 5 events, 11 versus 6, slightly higher grade 3, and 4 events, but it's still been manageable. Unfortunately, there was no difference in PFS or overall survival. Jeff has subsequently published these data. So ironically, low-dose RT, or at least standard-dose RT, 60 gray with chemo alone, does as well or better than approaches trying to increase the radiation dose or graft cetuximab into the mix. There are some interesting biocorrelatives. This is looking at EGFR. High levels of expression, you do see a potential benefit in the cetuximab subset. Unfortunately, we really haven't pursued that further, and I think that's still an open question that needs to be addressed. So are we surprised? Probably not. RTOG 0522 is an analogous trial in head and neck cancer, looking at platinum RT with or without cetuximab. Here, too, you see absolutely no benefit for progression-free or overall survival. And then we have a CLGB trial looking at carbo-PEM with radiation with or without cetuximab. And again, although this was just a randomized phase 2 and really wasn't powered for a significant difference, these curves are pretty much superimposed. We'll finish up with immunotherapeutic approaches, start off with the vaccine and end up with checkpoint inhibition, which is largely the Pacific data. So tisametide was a vaccine, liposome-based MUC1 vaccine. By way of background, MUC1 is a mucinous glycoprotein that is overexpressed and aberrantly glycosylated in non-small cell. And in preclinical studies, vaccination produced a helper T-cell response and a potential anti-tumor effect. There was a randomized phase 2 in both stage 4 and 3B non-small cell that looked at best supportive care with or without this vaccine. And if you look specifically at the 3B population, you see a significant improvement in survival, at least at 2 years, with a p-value of 0.0194, about a 30% absolute improvement. And that laid the groundwork for the START trial, which was essentially the same trial but done specifically in individuals definitively treated for locally advanced non-small cell with chemoradiation. Could have been induction followed by RT or concurrent chemoradiation. And this is, to the best of my knowledge, the largest phase 3 trial ever done in locally advanced. It was 2-to-1 randomization to semitide versus placebo, and unfortunately not positive. You see about a 2-month difference or maybe a 3-month difference in median survival, but the p-value is 0.123, a hazard ratio of 0.88. Intriguingly, if you look just at the group that got concurrent chemoradiation, it's a huge number. It's 806 patients. That's larger than the accrual to the Furisi trial, the prior RTOG trials. The hazard ratio drops to 0.78. And confidence intervals don't overlap unity. And many of us question why we didn't pursue this further, but there apparently have been subsequent randomized phase 2s where in the setting of concurrent chemoradiation where that has not really panned out. But one wonders if a vaccine approach might still have a role, particularly in the context of immunotherapy going forward. So finally, PD-1, PD-L1 inhibitors, are they rational, are they safe, and can they be effective? Well, anti-PD-1 immunotherapy has certainly demonstrated activity in lung cancer. You're going to hear all about this tomorrow, but there are 4 separate prospective randomized phase 3 trials in second-line setting, which have shown survival advantages for nivolumab, for pembrolizumab, and now atezolizumab. We know that PD-L1 or PD-1 inhibition can potentially see an enhanced efficacy in the minimal residual disease state, where I would argue immunotherapy may have its greatest use, well suited as consolidative therapy after definitive chemoradiation. Radiation can upregulate PD-L1 and cause release of tumor antigen and pro-inflammatory cytokines that could potentially enhance the immune response. And there are preclinical studies in mice that show that anti-PD-1 therapy and other immunotherapy approaches can enhance the efficacy of radiation therapy, again, through T-cell-dependent cytotoxic mechanisms. I'm not going to go in detail, but this is across a wide variety of malignancies. So these are just select immunotherapy trials. The list grows weekly. Some look at Nivo or Pembro either concurrently with chemoradiation or sequentially, but the probably the most important and most recent data are the Pacific trial looking at durvalumab. So this is the study design, phase 3 randomized double-blind placebo-controlled multi-center approach, a global trial. Folks had to have stage 3 disease, absence of progression following at least 2 cycles of platinum-based chemo concomitant with radiation therapy. 2-to-1 randomization of durvalumab every 2 weeks for up to a year versus a placebo control. You can see the stratifications were based on age, sex, and smoking history. Good performance status, again, minimum 2 cycles of platinum-based chemo. Originally, there was a minimum radiation dose of 60 gray, but I'll show you data where apparently a fair number got less than that. No active or prior autoimmune disease or history of immunodeficiency. Any other severe uncontrolled systemic disease would be an exclusion, and no active prior documented inflammatory bowel disease. And these exclusions have been essentially standard amongst all the IO trials and certainly boilerplated into this effort. So those of you who have been paying attention saw the press release this past summer where, quote-unquote, durvalumab significantly reduced the risk of disease worsening or death in the phase 3 Pacific trial for stage 3 unresectable lung cancer. So here is the presentation from ESMO. It was up just 2 months ago and updated last month in Yokohama, Japan at World Lung. Again, the statistical analysis is shown here. So there were co-primary endpoints of both PFS and OS. PFS, they were looking for 95% or greater power to detect an HR of 0.67 with a fairly rigorous two-sided p-value of 0.025. And for OS, which we have not yet seen, doesn't mean it's not positive, we just don't know the data, 85% power to detect an HR of 0.73, and again, that same two-sided log rank test. Here are the demographics. No data on PET. Apparently, a significant percentage of individuals in this study did not undergo routine PET imaging. You see a wide range in radiation from 54 to 66 gray. We have no specific data for less than 60 gray. Median age here was fairly typical of the population, 64 years, 70% were male. Fewer than 10% were never smokers, so I think this is pretty representative of the patients we see. Squamous was nearly half, 43, 47%. And if I can just go back, we do see a slight imbalance in PD-L1. 25% or higher was actually higher in the durvalumab arm, 24% versus 18.6%. Right off the bat, we see a potential benefit, 43% completing all 12 months of treatment in the durvalumab arm compared to 30% in the placebo group, and the placebo group appropriately a higher percentage receiving subsequent treatment. And this is the primary endpoint. And to be honest, this is probably one of the most striking curves I've ever seen in locally advanced non-small cell. You see more than an 11-month improvement in progression-free survival by blinded independent review. The placebo group is 5.6 months. Remember, the clock starts ticking at the conclusion of chemoradiation, not at the initiation. And for the durvalumab arm, 16.8 months. At a year, there's nearly a 20% difference in PFS and about a 17% difference at 18 months. Here are the subgroups. The 25% or higher PD-L1 expression group, you see a relatively greater or better hazard ratio, but pretty much across the board, with the exception of the small numbers with EGFR mutation, there seems to be a consistent benefit. Intriguingly, for the never smokers also have a marked benefit with the HR of 0.29. You also see a higher response rate. So these are folks who have already responded, but you see further response during the course of the durvalumab. So 28% versus 16%. P-value here, again, is significant, less than 0.01. And a reduction in the incidence of new lesions across the board, be it brain mets, liver mets, lung mets, you name it. The numbers are lower in the durvalumab arm. Time to distant metastasis or death are shown here, but again, this is not an overall survival curve. We have not seen those data. Safety, clearly reasonably safe, a slightly higher discontinuation rate for durvalumab. Grade 3 and 4 events, though, are pretty much equal across the board. You see a higher rate of fevers, of rash, of hypothyroidism, as we typically seen with this class of drugs, about 12%. And when we look specifically at pneumonitis, somewhat higher rate of any grade, 34% versus 25%, but grade 3 or 4 is incredibly low in this setting, 3.4%, and leading to discontinuation 6.3% versus 4.3%. So a positive trial, certainly with respect to toxicity, response rate, PFS, and lower incidence of new lesions, but the study remains blinded to OS. And notice they don't say it's the standard option. They say it's a promising new therapeutic option in patients with stage 3 locally advanced unresectable non-small cell of completed chemorads. New England Journal publication. So these are my concerns. Number one, we still haven't seen the survival data. The control group, I would argue, underperformed with respect to PFS. You go back to the RTOG trials, and even accounting for maybe the 6 or 8 or 12 weeks that they got the chemoradiation, we're usually in the 10 or 11-month range for median PFS, not 5.6 months. Significant percentage of patients do not undergo pretreatment PET. And so one wonders, you heard the talk from Dan Prima, up to 18% may be upstaged by PET who are otherwise negative on CT. So in that group, you're CT occult, but PET detectable metastases, you're basically treating durvalumab versus placebo. And needless to say, the IOs are going to do better. We do see some imbalance in the percentage of patients with 25% or higher PD-L1 expression, and we have no data on the percentage who received what I would argue to be suboptimal radiation, and no data on the nature of the concurrent chemo or subsequent systemic treatment. Nevertheless, certain current trials are going to probably fall apart. This is 3505. Jeff will address this, but this is Nivo versus placebo in the same setting. I think it's now of historic interest. Is that right, Jeff? And other trials are attempting to integrate these agents concurrently with chemoradiation, and the buzz, at least so far, is that it's relatively safe. There is interest in looking at, again, unresectable disease, looking at induction therapy with PD-1, PD-L1 inhibitors, a number of trials that are looking at that. And finally, in our group, we're looking at reirradiation with protons followed by a year of pembrolizumab. So my conclusions are here. Unfortunately, I went over, and I apologize, but concurrent chemoradiation with platinum-based chemo provides a survival benefit compared to sequential chemo followed by RT or RT alone. The current evidence supports the use of either a platinum etoposide regimen or PAC-carbo. There is no benefit to angio inhibitors, empiric cetuximab, TKIs, or RT dose escalation, and the new agents look quite promising, particularly the data we've seen with checkpoint inhibitors, and I think Pacific provides the first glimpse of a pathway forward and hopefully will translate into survival benefit, but again, we have not seen the OS data. And as Dr. Mulshine indicated earlier, you look in the right upper hand of the slide here, you see both the cause and the effect in the left lower lobe. So cigarette pack with this patient. So thank you for your attention.